Yeah, stop sharing and you come.
Hmm?
Stop sharing and you should don't use.
Okay. A very good afternoon to all of you and a warm welcome to this Friday webinar. So glad to see all of you are back here to listen to us. And today, as you all, those who have been attending the webinar regularly will be seeing Stella Townsend, but due to some personal reasons, she is not able to attend the webinar. And I am Dr. Nithya Pari, and I am the CEO of Skills Summit. So I'll be giving the introduction, and then, of course, it will be taken over by Dr. Pari and the speaker for today. So let me share my presentation. So am I visible and audible? Can you see the slide, Jayanti?
Yes, ma'am.
Okay, thank you. So as you all know, today's topic is acuity-based nursing, the benefits, challenges, and new solutions. And as we had already announced, today is going to be a special webinar where a participant is going to present as well. And as you know, we had announced the championship for this acuity-based nursing implementation. And we had a lot of responses for that. And we had a lot of jury who were, who were evaluating that. And we had shortlisted a few, and in that, this was the best presentation. So she's the presenter today is going to be the champion in acuity-based nursing implementation. So as we normally do, I'm just going to give you a quick introduction about Skills for Med, and then we will start today's webinar. So Skills for Med was established in the year 2018, and we have been committed to providing comprehensive training programs designed to enhance the capabilities of healthcare professionals. So all healthcare professionals are targeted, and our nurses who are the backbone and heart of the hospital are close to our heart as well. And we have 10,000 plus healthcare professionals who have benefited from our courses. And we have 75 plus hospitals in our network and who have been benefiting from our courses. And we have 50 plus course topics which we are doing, which we are providing to everyone. So as I would like all of you who have not joined us to join us along with the 10,000 healthcare professionals who've been upskilled with us. And we want you to become a part of a growing community of healthcare professionals who are enhancing their skills by attending our courses and benefiting from our courses and getting and building their confidence and transforming patient care. So I just like to quickly go through our learning pyramid. So our logo, Skills for Med logo represents this learning pyramid. And as you see in the base of the pyramid is a service excellence skills. This is a stage one where this stage one courses should be taken by all healthcare professionals. In this service excellence skills, we provide courses on communication, professionalism, and how to prevention of infection, infection control and prevention courses. These are the basic courses which we do in the stage one, which we think that all healthcare professionals in the hospital who are in contact with the patient should undergo these courses. And next, in stage two, we have core patient care skills, where we focus on the procedural skills, which is going to be delivered to the patients. And nurses should excel in this and develop the skill and become proficient and efficient in the core patient care skills. Then next, once you become proficient in that, I think we need to go into the specialization skills, which is in the stage three, where those can sort of try and upskill themselves in specializations like labor room nursing and emergency room nursing and critical care nursing. So then they will develop, they'll become more specialized and more focused in their practice. Then finally, in the peak of the pyramid is the leadership skill. So those who have really experience and become specialized can think of becoming leaders. They become leaders with the high level of skills, and also by seniority, they become the CNO or the nursing superintendent of the hospital. That is the vertical growth that happens, and we have courses for that as well. Then we have courses for the horizontal career path growth as well, where the leadership not only focuses on as a nurse, but they could become take the administrative role, become CEOs or hospital administrators. So we have courses for that as well. So this is a quick overview about our learning pyramid. So I'd like to announce there's a special offer, and I want to talk about our special flagship course of Skills for Med, which we are doing in collaboration with 𝐀𝐜𝐿. And it is a very interactive and practical career boosting course. It's a self-paced course because all nurses are very busy in their practice, so they can take it at their own pace. And right now, when it has been developed by great course leaders, the course is very comprehensive, and it's a very good course to be taken by the infection control nurse. They can upskill themselves, or the nurses can go through this course and become infection control nurses. And we have a sale going on now. Anybody who's interested can scan this QR code, or if can't do it now, can later contact us to take this course. Then we have a linked nurse course coming up, linked nurse course for hospital infection control. This is again a very comprehensive course. It's a one-day course. It's completely online, and it is coming up on, we do this once in 2 months. Now this month is coming up on 24th of August. It's from 9 a.m. to 5 p.m. And again, those who are interested can contact us and register for this course. And any more details, because I just gave a very quick overview. So anybody who's interested in our courses, and especially the ICN and linked nurse courses, can contact Ms. Jayanti in this number here. Please note this number, 91508 or you can visit our website, www.skillsformed.com. So today's webinar, as you all know, is going to be by two people are going to speak today. One is Dr. Parivalavan Rajavelu, who is a consultant surgeon, Sundaram Medical Foundation, and the founder of Skills for Med. As people have been attending our courses regularly, and many more people will know that he's a very passionate teacher. He loves to teach, loves to share his knowledge, and is very much focused into quality and patient safety. So that is why his passion and that drove him to start Skills for Med, and he's doing a lot of work in that. And then we wanted to have Mrs. Seema Chowdhury, who is nursing superintendent, Health World Hospitals, Durgapur. And as I mentioned earlier, she's our champion who's won the Acuity-Based implementation championship program conducted by us. And we are going to hear from her. But unfortunately, she was not well. She's down with the flu. So she's sending a representative, 𝐀𝐜𝐿 Sadhu, who's going to talk to us today. And Mrs. Seema Chowdhury, she's has 35 years of clinical experience, and she's specialized in OT and in critical care. It's very unfortunate that she's not able to talk today, but of course, 𝐀𝐜𝐿 will be representing her. So as we normally do, we're going to have a pre-webinar poll. So this is again not to test your knowledge, but it is to understand. So what is the awareness, and how much of, what is the implementation, and what are the, barriers you're facing. So that is what we want to know. So I think all of you can see the poll on the screen. So you can start answering. So we'll give you about 3 to 5 minutes to answer. So please jump in and start answering. So it will be very useful for us to know what is, understanding all of you have on acuity-based nursing, and what are the barriers you're facing. All that will will help us to know all these aspects. Yeah, I think they've started answering. Yes, please jump in and answer, because you have only 3 minutes to go. Thank you so much for answering. I want more people to come in and answer these questions. Last question, as usual, is interesting with the movies in it. So we can associate better. So question 1 says, what is your current understanding of acuity-based nursing? Question 2 says, how many years of nursing experience do you have in managing patient assignments? And what do you think is the biggest challenge in moving away from traditional fixed nurse to patient ratio? Which staffing approach is primarily used in your healthcare facility? And of course, the last question. So I think acuity-based nursing is a very new thing for all of us. And it is a challenge for everyone when it comes to assigning nurses to patients. So I hope this session is going to help all of you. I think I'll just give another minute so you all can try and complete the. More people are answering. Thank you. 30 seconds more. I think I will end the poll. Okay, I'm going to end the poll here and let's see what the answers are, and we can. Yeah, I think the results are being shared. Now I hand over to Dr. Pari to discuss about this poll and take over the presentation. Thank you so much.
Good afternoon, everyone. I hope all of you are looking forward to the festival season coming up next week. But today we will have a very interesting topic, and I think we'll start with discussing the poll. So we had asked the first question is what is the current understanding of acuity-based staffing? So out of which 47%, almost 50%, how you have said comprehensive knowledge and implemented in practice, which is very good. And equally, equal number have some knowledge, and about 20% are probably new to this topic, which is typical, I think, as this is a very new thing, and because of NABH, we have started implementing it. But I think it is a very, very important system to implement if you want to have better patient outcomes and also have good satisfaction from your staff. So I'll talk more about it before we go to the guest speaker today. The second question was about how many years of nursing experience do you have in managing patient assignments? And I think most of you are more than 2 years, 5 years, and some of you are less than 2 years. So it's again shows the interest from the middle level group who really are implementing this acuity-based staffing. So I think almost 70-75% of you are in that particular bracket. And what is the biggest challenge in going from traditional fixed nursing, that is something like 1:4 or 1:6 to this sort of flexible system. So let's see what is the highest. I think it's equally three important reasons comes up: resistance to change from staff and management, time consuming, and difficulty in maintaining regulatory compliance. They are the three important challenges. And of course, lack of organizational support is the other thing. It's amazing how you would also realize this has been your major pain points, and this is reflected across the whole audience who have come from all over India. And which staffing method is primarily used? Traditional fixed, still about 50% are using that. Modified traditional with some flexibility around 20%. About 1/3 are using Acuity-based staffing. So that's again shows that it is a very new topic and most of us are just getting into it. So we'll try to get more understanding of this topic in this particular session. So thank you so much for answering and taking. There's one more question? Oh, sorry. I think this is the most interesting question. I forgot that. So traditional nursing staffing is like assigning roles without considering individual strength, whereas acuity-based nursing matches the right nurse to the right patient. So which movie scenario represents this shift? That is the acuity-based nursing. I think most of you said it's Avengers, moving from random hero assignments to strategic team formation. So all the superheroes join together in the Avengers. So I think all the best parts of the shift and rostering is coming together in the Avengers. Few of you thought it is the Harry Potter, where they went from rigid school rules to other methods, and another 1/3 thought it was Ocean's 11 from specialized role assignments. So I think I would also go for Avengers because it is not just only specialized, but I think even it is distributing the according to the strengths of each person. So I think Avengers fits most. Like each of those superheroes has got their own strengths. So and they are given their role accordingly. So I think that was a very interesting thing. I almost missed it. So again, thank you so much. So let's move on to the presentation. So the next, yeah. So what we're going to do today is I'll be talking about first the nursing, traditional nursing shifts and their advantages and disadvantages. Then I'll give an introduction about acuity-based nursing, and then I will move. We will more move to hearing our champion telling about their method of implementing acuity-based nursing in their hospital. So I'm really looking forward to that. So nursing shifts is what all of us are used to, and it is a fact of life for all nurses. So when we talk about shift allocation, we know Nursing Council and initially NABH talked about the fixed ratios. So it is assigning a set number of nurses to a certain number of patients. So 1:4, one nurse for 4 patients, or 6 patients in the regular wards, 1:2 in the IMCU, like that. Okay, so that is known as the fixed ratio. So here is the table which shows the INC, Indian Nursing Council guidelines of nurse to patient ratio. So general ward is 1:6. ICU or cardiac critical care unit is 1:1. NICU or a neonatal ICU is 1:2. Operating theaters, of course, is 1:1 or sometimes even 2:1. ER is 1:4. And so this is what is the traditional fixed ratios. Now, what are the drawbacks? So there can be varying levels of care. So one patient may just be a patient who just got admitted for surgery and waiting for surgery, so may not have that much work to do. But one other patient may have tracheostomy, NG feeding, pressure ulcer risk. So many things may be happening with that particular patient. So there are varying levels of care which is not taken into account in the traditional fixed ratios. So this leads to burnout and dissatisfaction among the nurses, and more importantly, compromises patient safety and outcomes. And it leads to two things. One side, there could be work overload, and the other side, there could be underutilization also. So both these things can happen in a traditional nursing shift. So this is how the traditional nursing shift looks like. Suppose, for example, you say the red are the high acuity patients, and the yellow are the intermediate acuity, and green are the low acuity. I will just now in a few slides also explain to you what I mean by high, intermediate, and acuity. But just to all of you will get an idea when we say high, intermediate acuity with that example I gave you just now. Okay, so we have about 1, 2, 3, 4, 5, 6 high acuity patients and 2 intermediate acuity. The rest are low acuity. Now, if you go by fixed 1:6 ratio, you would see a senior nurse with very high experience has got 2, whereas a nurse 2 who's got intermediate experience may sometimes land up with 3, and also one intermediate acuity and 2 low acuity. And a nurse with low experience may also end up with the high acuity, 1 intermediate, and some low acuity. It all depends on the charge nurse, how they are actually putting these people into the various rostering, and also depends on how sensitive they are to the workload. So it's very, very variable. It is not really, a standardized method, which is actually happening in the traditional staffing methodology of fixed ratios. But there are some advantages in traditional shift allocation. It is very simple. It is predictable because we know it is 1:6 in the ward, so we can manpower or a person power assignment is easy to achieve regulatory compliance. Now, as long as you can show that you are giving that ratio according to the INC guidelines, you are not stepping out of regulations. And easier for administrator to allocate resources and budgets. How many nurses to recruit is easy because you know that it is only a fixed ratio, and ensures a baseline level of nursing care. That's what we have been doing for so many years. So we can't say that it didn't work. The excellent care has been given even with traditional fixed ratios. And also it is very easy for the experienced nurses, if they want to become charge nurses, very easy to train them. How to do the rostering and how to manage a shift is very, very easy. So these are the advantages of the traditional shift allocation, though as I told you, there may be several drawbacks as well. Now, one important thing we have to think about is the more is not always better. That is, I'll explain that. So the traditional is a fixed nurse to patient ratio, 1:5, 1:6, and same ratios applied regardless of patient complexity. So what happens? So some nurses may be able to manage, as you can see this nurse, she's 1:6 also, she's managing very comfortably because she's experienced, whereas some other nurses may struggle with this. As you can see, this nurse is really, finding it difficult even with the 1:5, which probably because 2 of that patients may be very highly demanding, time-consuming patients. Not that she's less experienced. So because of this, patient outcomes and nurse satisfaction both suffer. So just saying 6 patients, 5 patients, 2 patients, just patient count is not enough. Because one patient could be a stable, independent patient just on routine medication, or could be patient B could have complex mobilities and have lot of care. Like I told you, they may have a tracheostomy tube, they may have a feeding tube, they may have a bed sore, and there are a lot of medication, more than 10 medications to give, some IV, some IM. So the time you have to spend for this patient is definitely more than the time you have to spend for this patient. So this is what leads to burnout. So in that particular shift, though we say, it is an 8-hour shift or 12-hour shift, what is the time actually you spend with patients is what is really taxes us. So for this patient, you would have probably spent 15, 20 minutes in the whole shift. Whereas in this particular patient, you would be, you would have spent about more than 1.5 hours to 2 hours in that shift. And if you have 3 such patients, you can imagine what will be the workload. So, but in the traditional thing, in the traditional staffing, both count as one patient. And the workload varies sometimes 3 times or 5 times between these extremes of patients. So this is why just having 1:6 or 1:5 is not enough. So the whole logic of changing from, people might ask, why do I want to change from traditional to Acuity? I am so happy with this, and so easy to do. Why should I change? So this is the argument. So it's not just by numbers, you're not actually taking into account the complexity of care and time you need to spend to take care of a particular patient. So this is known as the static ratio, 1:6. It doesn't change. And to an acuity-based, which is a dynamic, the staffing adjusts based on the collective patient acuity, and it varies from shift to shift. Here also it varies from shift to shift, but it is not just 1:6. Only the nurses are changed. Here, the nurses being allocated to the patients and the ratio also can change dynamically. And it responds to real-time changes in patient conditions and balances unit-level workload rather than simple patient. So the total unit workload is distributed equitably among the nurses, taking into account their experience and competency. So these are the 2 reasons why we are shifting from fixed, static, traditional staffing to acuity-based staffing. So this is a pictorial way of representing it. We are balancing staffing with the specific needs or acuity of the patient, and that is the whole crux of acuity-based nursing rostering. Now, what is, you need to understand certain terms. As I told you, I will explain that. Patient acuity. What do you mean, when you say acuity-based nursing or staffing? So it is based on the patient acuity. So what do you mean by patient acuity? It is the complexity of treatment you give and the intensity. So are you just giving them 2 medicines orally, or are you giving them 10 medicines plus some IM injections and some IV in the same shift? So it's very intensive. In that particular patient is intensity is more, and the severity of the care. So the more acutely ill patients, the more the care has to be more complex. So we need to find out the patient acuity by systematic assessment of each patient's care requirements, and this is what makes it very time consuming, and it is very dynamic. It changes from shift to shift or even within a shift because of the changing patient conditions. But the whole goal is to put the right nurse with the right skills for the right amount of time to match the patient. So that is the, if somebody asks you to talk about acuity-based nursing, we take into account the acuity, patient acuity. And what is this patient acuity is what I just told you. So most systems will classify patient acuity into 4 or 5 levels, mostly 4. So I'm just going to explain what are these 4 levels. So level 1 will be low acuity, that is minimal care, independent, stable condition. So I already gave an example of a very ambulant patient, young patient, 25-year-old, who probably has come in for a hernia surgery. Let us say surgery is tomorrow. So your shift, all you have to do is just take his vitals and probably inform the theater and surgeon that this patient has got admitted. So this is an example of a low acuity, that is level 1, minimal care, independent, able to do all the activities of daily living, and hemodynamically stable. Level 2 is what is known as moderate or sometimes called intermediate acuity. Some assistance is needed, stable with monitoring. So probably you got to give some more assistance, maybe you have to give some medicines, you got to give some IV fluids. So this is a moderate. And then level 3 will be high, frequent interventions, unstable in maybe vitals and the complex care. So this is an example I gave where maybe NG feeding is required, patient requires 2 hours turning because of the pressure sore, or patient is incontinent, you need to keep changing the diapers. So these are all, the complexity is there, and also the patient is on some medications and the BP goes going up and down, so you need more intense monitoring. And finally, the level 4 is critical. Mostly these patients are in intensive care and needs continuous monitoring. Multiple systems are involved, organ systems are involved. But many times patients who are getting discharged from the ICU also may sometimes fall into this level, because many hospitals, because of lack of ICU beds, this happens. They keep transferring patients on BiPAP and things like that into the general ward. So you could have all these 4 types of acuity in your ward, and this is what makes it very challenging if you just give a traditional shift. So very important to understand that each level translates into specific nursing time requirements. Actually, the whole acuity-based staffing is based on the amount of time you have to spend with the patient. That is a very convenient way of finding out how complex the thing is. So the more complex, the more severe the patient condition, naturally the more time you have to spend. So it makes logic to use that as the parameter to do your rostering. Putting the nurses in the various to the various patients will mostly depend on the nursing timing requirements. So here is one example. I told you about traditional. We are using the same example. Let's say this particular ward has got 16 patients. Okay, so there are 16 patients in a ward and there are 3 nurses. Okay, nurse 1 is very senior, very highly experienced. Nurse 2 is a junior, intermediate in competency. Nurse 3 just finished nursing college and entered the hospital. Her first week in the hospital exposure. So these are the 3 nurses and we have 16 patients. How do you do that? So in that, now if you, the first thing you have to do is competency. You should know the competency of your nurses. The second is to assess the acuity. As I said, there are 4 levels or 5 levels, but here just for explaining, I have taken just 3 levels. Red is high acuity, yellow is intermediate acuity, and green is low acuity. So you have about 6 high acuity patients, 2 intermediate acuity, and the rest are all low acuity in this 16 bedded unit. Now, we already saw how this is going to be done in the traditional unit. Now, how will we do it in the acuity-based nursing? So if you see, the nurse 3 is not given any because she just come 1 week into nursing. She has to be given all the low acuity, and probably one of the high senior nurse will be supervising her also. And then if you look at the intermediate, given 2 and 2 intermediate and 2 high acuity patients, and the senior nurse takes 4 high acuity patients and 1 low acuity. Now, if you see here, the ratios becomes 1:7, 1:4, 1:5. Currently, this is not according to INC standards. So the whole conflict we are facing today, as of today, I hope it changes with the INC understanding this acuity-based nursing and changing their stance. Currently, you have to satisfy 2 regulators, one accrediting body which says acuity-based nursing, that is the NABH, and another is the Indian Medical Council and the Indian Nursing Council, which are still into fixed ratios. So now to satisfy both, it is always difficult to satisfy 2 bosses or 2 spouses, right? So we now have 2 bosses. So this is where the whole confusion comes. If the fixed ratios are not there, then I would certainly do this. Put 1:7 for the low, because basic competency, very low acuity, you can stretch it. Or give the intermediate person even 1:8 or something like that. And do some other permutations, combinations. Right now, it is not possible. So we are in the transition stage. So keeping both the regulations, we have to somehow manage this acuity-based nursing. So that's how it works as of today. So for people who want to, we saw in the poll that many people are new to it and want to implement it. So how do I implement? So you have to take it small and take it step by step. So first thing is you should know your nursing competencies. So for nurses who have been with you for a long time, you already will know that. But anyway, it is better to go through a formal process of assessing the competency and documenting it. And then every shift, at least try every day, collect the acuity data from the patients. Okay, ideally every shift. And based on that, you will have to calculate the staffing needs and make patient assignments. So this is what you have to do. And this is the thing you have to do every shift. You should know the nursing competencies. You should have the data for the patient acuity for every patient in your ward. Then based on that, as I told you in the previous slide, you calculate the staffing needs. So there are several ways to calculate staffing needs. We can't go into detail today because now we have the guest presentation also. They will be able to tell you how they do it. But there are several ways. As I said, the time is the most important thing, and we can calculate that. And the fourth is, based on that, you allocate your various nurses to the patients in the ratios, which you think it is appropriate. So the benefits of acuity-based nursing are improved patient care. Several studies have shown that. There's no doubt about that. There is balanced workload, increased efficiency, both for the nurses and for the management. And there are challenges and barriers. Resistance to change, you already pointed out. Time-consuming came out in the polls. Non-compliance, lack of organizational support. All these are important challenges. And there is also inconsistent patient acuity assessments. So each of us can develop our own method of doing assessments, but there are no established methods of assessing this patient acuity assessments. So use one of those established methodology. And sometimes your staff may not be willing to be that flexible. And all this is a lot of data. Very, very difficult to manage it manually. People who are having electronic medical records or HMS systems will find it more convenient to do this. And sometimes if you buy software, so there are no software available in India. The important ones are pretty expensive. So high implementation costs if you want to do it. But hospitals with very high bed strength, 300 beds, 600 beds, it's impossible to do it manually. They have to go for the sort of software, and the implementation cost becomes very high. So how do we start your acuity-based implementation journey? So select a validated acuity tool appropriate for your setting. So you can develop, there are so many tools available manually also. You can select one of that. Start with one unit and do it for 3 to 6 months. Fine-tune your methodology. Meanwhile, educate your staff also on this system, both the charge nurses as well as the nurses, so that everybody knows what you're talking about. Evaluate the results in the pilot unit, refine it, and then once you're satisfied, then you can expand it. So that's what I wanted to talk to you. Very broad overview of acuity-based nursing, what it is and why it is being implemented, and what are the patient acuity levels, and how you can implement it in your own hospital. I didn't go very much into specifics. We did do a webinar on acuity-based nursing a year ago, and that is available in YouTube. I think my team has actually taken bits of it and also put it in the YouTube for this week. where I explain more in detail about the methodology. So go to our YouTube channel, Skills for Med. If you search in YouTube, our channel will come up, and I think you'll see if you want to see the whole webinar, also it is there. Also, some 15-minute videos are also available in our YouTube. So you can watch that to get more details. Now, I think we are going to the most interesting part of our webinar today. But at this time, I just wanted to just do a commercial break. So let me just stop sharing and share that particular slide where I wanted to show you something which was announced in the beginning, but not many of you had actually signed in. So I thought it's probably good to do that. So let me share that. Okay, so here it is. So this is our special offer. ICN course is our flagship course, and I think Diwali is coming next week, so we're not saying it's Diwali sale, but basically every now and then we put this special offer for ICN because there are so many interested people, and many times it is beyond the reach. So we are now, having this, which was it's actually 9,999, but with the GST, it comes to 11,999. So as you can see, we have combined with 𝐀𝐜𝐿, collaborated with 𝐀𝐜𝐿, and we have fantastic faculty who have put this course together. And it's a self-paced course. So you can register. This QR code is available. And I think our admin lead, Jayanti, will put this poster in the comments at the end of the webinar, and also the link to register now. So it's going to be for a short time, so take advantage of that. So thank you for that commercial break. We'll now get back to our presentation. So I request just a minute. Okay. Now, who's you're going to take over?
Smigda.
Smigda. Okay. So
Smigda Sadhu.
Smigda Sadhu, welcome. Can you switch on your camera?
Yes, sir. Very good afternoon, sir.
Good afternoon, Snigdha. Welcome, and we are looking forward to your presentation. So
Thank you
please
very much, sir.
introduce yourself, and you can go through your presentation. And I think the time constraints have been explained to you, isn't it?
Yes, sir. Sure.
Right. Okay, please go ahead.
So, good afternoon, everyone. My name is Smigda Sadhu, and today I am representing Health World Hospitals. Thank you. I would like to extend my heartfelt welcome or a heartfelt thank you to Skills for Med platform, which has given us for today's presentation to share with all of you. So our project's focus is how we have implemented acuity-based allocation or patient classification system in this hospital to improve the nursing practice and to strengthen the quality of nursing care. So I'm just sharing the screen. So first I'm going to introduce about staffing model prior to acuity-based nursing. So previously, as other hospitals, 3 shifts like morning 8 a.m. to 2 p.m., evening 2 p.m. to 8 p.m., and from night 8 p.m. to 8 a.m. So each shift has designated ward in charge responsible for reviewing acuity scores and assigning the nurses. Staffing logic: allocating the nurses based on staff's competency. As sir has already said regarding, we all need to know the staff's competency and patient's acuity category. Maintaining nurse-patient ratio as per NABH standards. And the constraints were limited staff availability during the night shift, variability in patient census and acuity fluctuations, need for continuous training on acuity assessment and documentation. So previously it was like fixed allocation for ICU 1:1 or 1:2, and in the wards 1:5, maximum 1:6. So pre-existing key pain points or drivers for change. So what are the need that we thought we need to change the acuity or patient classification system? So there was unequal workload distribution. Previously, nurses were assigned patients based on fixed number of patients rather than care complexity, leading to workload imbalance and staff fatigue. Whatever be the, suppose in a 12-bedded ICU, if there is 12 patients, then and staff available is 4, then it will be divided as 3 allocations to each of the nurses. But we are not thinking the care complexity of the patients. So there will be unequal distribution and the burnout of the nursing staffs. Next is lack of objective staffing decisions. Without a structured acuity system, staffing relied on subjective judgment. That is, whoever is the senior most or the ward in charge or the shift in charge is responsible for staff allocation. They, according to them, if the patient is stable, then they are giving the allocation to the staffs based on their experience, based on their subjective experience, not by the standard standard frame of like some parameters. So quality and safety variability, differences in patient dependency levels were not systematically identified, leading to potential lapses in care quality. Acuity framework. So in our hospital, what we are following is Fuglin et al. That standard acuity or patient classification system. In that, there is 4 levels, level 1, 2, 3, and 4. So level 1 is self-care or minimal care. So for that, we are giving 0 to 12 points, and allocation we are giving more than 5, maximum 1:6. Level 2, that is moderate or intermediate care. For that, acuity points are 13 to 24 and maximum allocation is 1:5. For level 3, that is intensive care patient, 25 to 35 points and allocation ratio is 1:2. And level 4 is highly specialized or critical care, that point is 36 and above. So what is the self-care or minimal care? So according to this clinical definitions, what we are decided to have that patients are conscious, oriented, independent in ADLS requiring minimal nursing supervision is categorized as self-care or minimal care is needed. Then level 2 moderate or intermediate care, patients are partially dependent, require assistance with some ADLS, needs intermittent monitoring. Then level 3 is intensive care, that patients are hemodynamically unstable or at risk of deterioration, require frequent nursing interventions. And level 4 is highly specialized or critical care. So in that, patients are very much critically ill, unconscious, ventilated or on vasoactive support, needing one-to-one care and continuous monitoring. So I have given some examples also for level 1, that is stable minor post-op cases. You can assume like a patient undergone appendectomy surgery. So in that case, you can have level 1 or patient can do by ADLS by himself or herself. Level 2 is first or second post-op day patient. Level 3 is stroke patients requiring frequent assessment. Because stroke patient needs continuous neurological assessment, we need to evaluate if there is some further brain injury, signs of brain injury, so that we need continuous frequent assessment. And level 4 is highly specialized. Any patient who are mechanically intubated, ICU patient, they are classified as level 4. Then we have acuity scoring variables, points, and thresholds. As already I have said, we are using Fugulin et al. That standardized framework. So in that list of variables are 12. First one is mental status, second is oxygenation, third vital signs, motility or mobility, walking, feeding, body care, elimination, therapeutic, cutaneous or mucous integrity or tissue impairment, dressing, and last one is the time used for wound dressing. So here you can see the elaborate description of each variable, how you can score. So you will be having less score, that is patient is more stable. So mental status, you can see that score 4 is unconscious. If the patient is unconscious, it is score 4. And the less score is orientation in time and space. Patient is fully oriented with time and space. Same oxygenation, patient is in mechanical ventilation or volume pressure or volume ventilation, you can score 4. And score 1 is patient is totally not at all depending on oxygenation. Then vital signs. If we need to assess the vital signs in an hourly or less than an hour, like 15 minutes interval or half an hour interval, then we can give score 4. Or as a routine, if we are assessing the patient as a routine vital signs check, then we can give score 1. Mobility or motility, patient is incapable of moving any body segment, that is score 4. And score 1 is patient can move all body segment. Walking, patient is restricted to bed, is given as score 4, and patient is not walking is given as score, patient is self-walking or self-mobilized, that is score 1. Feeding through central catheter and feeding, self-feeding is given as score 1. Then the next point is body care. That is patient is fully dependent on nursing care is given as score 4, and patient is having independent care. Patient can do all the ADLS by himself or herself is given as score 1. Elimination needs evacuation in bed and use of urethral catheter to control the diuresis. If a patient is having catheter and patient is eliminating in her or his own bed, then the patient is given as score 4. But if the patient is self-sufficient, patient can go to the toilet, patient can have elimination by own self, then it is given as score 1. Then therapeutic use of vasoactive drugs to maintain the BP, and if the medications are given through oral route, then it is given as score 1. Then cutaneous mucous integrity, it is the most important part. So you can see that many patients are having bedsore. So for that we need to assess the skin condition in this point. Presence of continuity solution, that is continuity loss in the skin, destruction in the includes dermis, epidermis, muscles, and other skin structures such as tendons and capsules, then we are giving a score 4. But if the patient is having intact skin, then we are giving score 1. Then the last 2 points regarding dressing performed more than 3 times per day, then patient is given a score 4, and patient do not have any dressing to perform, then it is given a score 1. Then last time used for wound dressing, more than 30 minutes. If it is needs more than 30 minutes, then we are giving score 4. But if totally no dressing is needed, then we are giving score 1. So this is how you can calculate and you can get the total score of the patient. Then however, whatever you are getting the points, total points, according to that, you are separating or categorizing the acuity levels. Like previously, I have already said 0 to 12 is level 1, 13 to 24 is level 2, 25 to 35 is level 3, and 36 and above is level 4. So we have given some walked example how it works. For post-op elderly patient, we have taken an example who needs full assistance, who is unconscious, monitoring continue, needs vital monitoring, bracing is needed more than 3 times. So like that, such examples we have given on the basis of the parameters. So total score is 36, then acuity level is critical care. So here example 2 is given, that is for a stable medical patient who is having limited movement, monitoring 4 hourly is needed. For vitals, wound care is scoring is given as 1, like no dressing is there, medications are given intermittently, mental status patient is oriented, oxygenation status patient is not at all depending on oxygen, so score is given 1. Walking needs assistance, feeding is self-sufficient, body care is independently performing ADLS, elimination is self-sufficient. So the total score comes 13. So for that, it is level 2. So nursing allocation can be given as 1:5. So Acuity data capture and tools, how we are capturing the data. It is the method pen and paper. We are just every day we are printing the papers, and frequency of capture. Each shift we are capturing the data because the patient's status changes. Responsible person for data capture, ward in charge or shift in charge in each shift. So rostering logic and rules, how we can apply the patient classification system for staff allocation. First, we need to do patient assessment based on all the parameters what previously decided in that standardized framework. From that, we have to assess the patient, we have to calculate the total points, then we have to classify according to the total scoring, that is level 1 to level 4. Fourth point is calculate workload summary in a ward. Total workload summary we have to calculate. That sir has already said that staffing needs we need to calculate. So from that total workload summary, we are calculating the staffing needs. Then determine the required nurse allocation and nurse assignment based on acuity score and competency level. So already we are about to know regarding the staff's competency level, and we already got the levels of acuity scoring. So based on that, both we are just allocating the nurses for the patient allocation. So what is the impact and outcome after implementing the standardized framework for acuity? Improve nurse-patient allocation. More accurate and fair distribution of nursing workload prevents overburdening of the nurses. Enhanced quality and safety of patient care. Better continuity and safety of patient care. Objective staffing decision. So previously there was like subjective decision. The patient is stable or the patient is not stable. So now we have the documentation, we have the proof based on what are the parameters we are deciding the staffing pattern. So that is data-driven nurse staffing models. And the last one is improved staff satisfaction, higher job satisfaction and lower burnout for the nurses. So cost and scalability, there is not much more cost. Format printing and implementation is estimated level of cost is low to moderate, training and orientation. So overall cost is almost low to moderate. As a adaptability also, it is ease of implementation. Customization, you can customize according to your patients. Then staff acceptance and regulatory alignment. It is already framework NABH and nursing excellence accepted. Then scalability is from pilot to hospital-wide implementation. You can start a pilot study in 1 to 2 wards. Then you can just have the hospital-wide implementation, applicable to all specialties and predictive of staffing model. So that's all. It was the slide for me. Thank you Skills4Med for giving such a platform so that one can learn from each other's initiative.
Thank you so much, Snigdha. I think I have to thank Seema Chaudhary also. I think she's there, and she's had a I think viral flu that she couldn't come on stage, and you did a fantastic presentation. Thank you, and congratulations to you.
Thank you very much, sir.
And I think if others are wondering, even I could have made the presentation. I think what this has given us an inspiration that we should include all of you in our webinar. So from next month onwards, I think third week is what we have planned. We will any innovative practice in your hospital which improves your either your work or quality or care to the patient, you can showcase it on our Skills Summit webinar. So we will be announcing about this in the upcoming webinars also. So we request all of you to take part. This is so much of learning. I think instead of just us talking, getting you people on board and sharing your experience is a fantastic thing, and we learn as well. So please, take opportunity for that. So I think if I will just share a couple of slides to go. This one. Yeah. So this is our monthly schedule. So you can see, this is about Acuity-Based nursing, and these are the Friday webinars. And 24th of October is one missed dose and one wrong entry, lessons from medication reconciliation errors. So we're going to talk about medication reconciliation and errors which can cause on the next Friday. And the last Friday, we have a special guest, an experienced person who's going to talk about their life journey. So we can learn quite a lot. We will we'll tell you who that person is the next webinar. We also run online CNEs. You have to register for this in advance. And this month is all about surgical care. So this online CNE is actually an annual program. So it runs for a year, and every month there is a particular theme, either it's medication administration or IV, which every week there is a class. So for hospitals who don't have a regular CNE program, we are trying to bridge that gap by doing this. So that's about there. And I'm going to stop here for question answers. And you can scan this to join our WhatsApp community. So any questions, I'll be glad to answer that on Acuity-Based. I think the feedback link is posted in the chat box, if I'm not mistaken. I think Jayanti will be doing it. Yeah, it's already posted there. So any questions? So I think Mary Nisha asked, is the same tool used in all wards or ICU? See, my take on that is ICU by definition is all critical care, right? So the patients filter themselves, and you only admit those sort of patients there. So you could have a fixed ratio there, 1:1 and 1:2. It works very well. Whereas all in the other wards, I think definitely this system will be of use. So apart from that, I can't see any other question. Let's have a look at the Q&A. To Snigdha and Seema, what is the name of the Acuity tool used? Sheena Prasad has asked, do you have a name for the tool?
Yes, sir. It is already approved tool. It is from Pan American Association Fugolin et al.
Sorry, what is that? Can you say that again?
Fugulin et al. Fugulin, Fugulin et al.
We should put in the chat.
Okay.
And it is given from Pan American Association, sir.
Okay. All right. Thank you so much. You can actually, type that in the chat box so that no others can actually, probably Google it and find out. Thank you so much. And Gopal Madhuram has asked, how do we assess the competency of nurses? Please share if any standard tool exists. Yes, there are several standard tools, and I think we can actually put it in our WhatsApp group. If you're part of the WhatsApp group, we can do that. So Subramaniam Venkatraman says this applies in ICU also. I hope that is an answer. I gave my opinion. So this can be used in any setting. So Kalavan is asked labor ward and neonatal. Again, ICU, as I said, that I generally feel it's a waste of time. It's a very time consuming to do this. And ICU, you know those patients are critical. So why do you want to do an acuity-based staffing there? And labor ward also, all of them are requiring 1:1, right? So definitely, if the labor ward patient is in the ward, maybe in the first stage of labor, then they would be part of this particular scoring. But once they go to the labor ward, it really doesn't make sense to do this and spend a lot of time there. So Saravath has asked, in private ward, ratio of staff pattern is also used the same protocol. We are used to this method. Okay, yeah, thank you so much for that. So the link for WhatsApp is actually the QR code which is being displayed in the screen right now. So please scan the QR code and you can join the our WhatsApp group. No, OT is 1:1. No, again, no, you don't need to implement this in OT and cath lab because they are very specialized. And for every patient you operate, you need a scrub nurse, right? So, it's all set. You don't need to use this acuity-based system. It is where there are different complexity of patients, this acuity-based nursing has to be used. I think I should have put a slide to also say where all it could be used. But this is the logic. If you find a ward where there are different patients of different complexity admitted, then definitely acuity-based nursing works. But if they're all standardized, for example, in the critical care, in the operating theater, in the cath lab, they're all the same kind of patients with highly specialized care is required. So definitely, when they come to the unit, you need a 1:1 care for them. So that's what you have to understand. How do we do skill mix with acuity-based staffing? Yes, the whole challenge is that. So the whole once you know the competency of the nurses, you need to allocate the nurses according to their competency. Doing it manually requires a lot of thought put into it, and you can actually make mistakes. That is why having an automated system or an app is a good idea. Deepa Lakshmi says the QR code is not directing to the WhatsApp. Jayanti, can you please check? Otherwise, can you put the link, please, in the comment section?
Sure, sir.
Can you check if the QR code is working? I thought we checked it before we put it on the slide. Oh, now she's told it, she's received it. Okay, sorry about that.
You can put the link.
So many people are saying not working. Is it the link or is it the QR code? Shweta has asked, can you use this in HICC or infection control committee? I don't understand that question. So because
So patients.
What I can't understand what you're talking about. If you can clarify that. If you raise your hands, I can allow you to unmute and you can ask the question also. Anju raises a very practical question. If nurses is less, how can acuity staffing be worked out? Yeah, if you're very short of nurses, you can't work it out. This, definitely you need the minimum number of nurses to do this. So again, Mini Abraham says how to grade the nurses according to the level. There are several competency-based assessments available. Use one of those established tools to do that.
Seema has shared the Acuity tool name in the
Yeah,
chat.
yeah. Is the QR code working for our WhatsApp group?
I'm checking, sir.
The feedback link also, you can probably share it. I think there's been a lot of chats after that.
QR code is working.
It's working, okay. So the feedback link.
How they do the nursing category.
That works. I checked before sharing.
Okay, all right. You can share the feedback form. You already done that. Share the link for the ICN course also again.
Do that how to grade themselves. You can ask Nikta how they do.
She put, what is it?